last year when we lost the highway between here and Brookings, known as Hooskanogden, it had a significant and lasting financial impact on the health system. In that 15-day period, we lost what we estimate to be about $1.5 million in lost revenue and dollars spent to protect our market share. And we realized a few things in that event. That one, we were ill-equipped to help the Brookings market in an emergency situation. And we also realized, and we knew this from the numbers, but we really realized how dependent we are on that market financially for the health system to be financially viable and solvent. And so we started making significant inroads to open the emergency room as soon as possible. But we did have a visitor, Ms. Sue Gold, as a private citizen. She approached the board and requested that before moving forward with just an emergency room, that we carefully consider our options down the Brookings market, and specifically wanted to know if it wouldn't be a wiser decision for us to actually make an attempt to put inpatient beds down at the facility that's already existing on 5th Street. So we're not talking about construction, we're not talking about erecting a new building anywhere, but should we consider moving those beds? And so the board asked me to look into this in a limited capacity, because the first thing that we knew is, as a critical access hospital, we are obligated by certain regulations, and there are mild requirements between facilities. Specifically, in order for a critical access hospital to be deemed a critical access, you have to exist 35 miles from the nearest next facility, or 15 miles on mountainous roads, which the highway does not qualify for. We've already looked into that. And so the board wanted to know, based on this request, if you will, would state and federal regulations even allow that to occur? And if so, would a facility that supported inpatient services down the Brookings market require what's called a certificate of need through the Oregon Health Authority? And so I reached out to Gary Milliman, who used to be the city manager in Brookings, and asked, Gary, if you were me, who would you have conduct this study? I would need it to be somebody impartial, and I really need it to be somebody that understands the federal and state regulations. And so he steered me in the direction of the Portland State University. Specifically, I worked mostly with Jason Fowler. I'm sorry, this is kind of going in and out on you guys. He gathered just some basic information from me. It was mostly, what questions did we have, and I shared those 3 questions. And with he and his team, through August, they worked on pulling all of the regulations. I've been asked by Sue Gold if they actually interviewed people from CMS and at the state level, and I've confirmed that the report did not include any interviews. I'm wondering why this is doing that. I apologize. It's pretty distracting. But we didn't influence that study in any way, and so I didn't make a request that any interviews take place. I simply posed the questions and let them answer the questions as they might. And as they might, they did. They produced a report to us in August, as I mentioned, that essentially said it would be financially devastating to attempt to relocate inpatient beds to the Brookings market. Federal and state regulations would not allow it without putting our existing hospital in jeopardy of that status. And lastly, it would be subject to the Certificate of Need certification in Oregon. That Certificate of Need is an important thing to understand. They really want to know, is it needed, not is it wanted? And they would ask a series of questions that Portland State, determined, not necessarily our financial viability, but they looked at the capacity of number of beds that serve our current county, if you will, and they included Sutter beds. And so when you say Curry General Hospital has 18 beds and we run on average a daily census of 7 patients in the hospital, Sutter, I don't know what their bed count is, but they are nowhere near capacity either. And the state would simply look at that and say, you have plenty of bed capacity, therefore you do not have a need. And so it was felt very strongly that it would be very difficult to get past a Certificate of Need for the state given those scenarios. It just keeps blinking at us. I don't know either. So we move forward then, knowing this information and having that question asked and answered. The board set their sights on the emergency room in Brookings, and that's what I'm going to spend the majority of my time talking with you about. You can see some pretty significant statistics here. 20% of the average population in our country as an adult will need an emergency room visit at least once a year. Our population is older, it's more disabled, there are more veterans. I guarantee you our percentage of adults needing emergency care in our county is higher. 14,000 residents live in the South County and currently have to travel up to 27 miles to get to the nearest emergency room. And we know that approximately 90% of all emergency room visits are actually treated and what we call streeted, meaning we're able to take care of your need right then and discharge you home or back into the nursing home that you came from or back to your parents, wherever that is. 7% on average require an admission as an inpatient. You may have a condition that requires us to admit you to the hospital, and approximately 3% require a transfer to another facility for a higher level of care. And we'll get into some of how that's currently being managed down at CMC today and what it will look like in the future. But there is a strong business opportunity to improve access to care. It will allow us to expand our market share, and you'll see it's financially it does generate a margin for us that will allow us to continue to invest in our health system in the future. So I've pretty much covered a lot of this. The lack of emergency care is the case statement. Oregon actually did change its laws to allow for this freestanding emergency room to exist. And as I mentioned earlier, the weather here isolating us with road conditions is a significant concern and continues to be a concern today. Currently, if you walk into CMC or a patient and you're needing to be seen, I'm going to use the word urgently or emergently because we do see on average about 3 ambulances pick up patients from that urgent care every day to bring them to an emergency room. In the future, well, let me stay there. So the walk-in clinic is staffed 6 days a week, and it is staffed with a physician's assistant and well-qualified and trained nurses. But they're pretty handcuffed because if you were to present to them with a life-threatening situation, although they will do their best to stabilize you, they do not have access to what we call crash carts and certain medications that are need to be overseen by physicians that are emergency trained. And they essentially have to call 911 to have you picked up and shipped out. In the future, we will have a fully licensed facility from the Oregon Health Authority. It will run 365 days a year, 24 hours a day. It will have board certified or board eligible physicians overseeing that care 24/7. We will have registered nurses that are trained in trauma. We will have respiratory therapists and a complement of other staff such as laboratory staff and diagnostic imaging. In the future, under the emergency room, we will be able to actually stabilize a patient's condition and directly transfer them to a higher level of need if that's necessary for that 3% of the population. As I mentioned, right now, if you have a condition, you have to go to an emergency room before you are transferred to a higher level of care. There's been some concerns raised in the community that we will be eliminating our urgent care or our walk-in care, and that what we're really trying to do is funnel patients into a higher cost setting for healthcare, and that really couldn't be the furthest thing from the truth. And in fact, what we're doing to enable people to be seen that day on a less urgent situation, we are setting up, and we already have it running, what's called a same-day appointment clinic. So if you're feeling a little sick, maybe your child's been up vomiting all night, we've all been there, maybe you've been coughing for the last 24, 48 hours, whatever those minor ailments are, but you do need to be seen by a practitioner, you will be able to call the main number and they will schedule you with a provider that day. We will have appointments available with one provider from 8 to 6 p.m., 6 days a week, and it'll be first come, first serve. So really, if it's 4 o'clock and I'm calling to get an appointment, there is a chance that those slots are already filled for that day. We would then focus on getting you in the very next day. So it's intended to take care of that really non-urgent, non-emergent situation. If you happen to walk into Curry Medical Center without an appointment, there are laws. They're called EMTALA. You can read them in your leisure if you choose. But basically, EMTALA was, those laws were created because back in the day when we didn't have the Medicaid expansion program, we had, I want to say approximately 17% of our American population without any insurance. And when a patient would come into an emergency room and the emergency room would determine that they didn't have a payer source, they were unemployed, they didn't have insurance, they could never afford the treatment that was potentially necessary, they would just transfer them to another hospital. It was called patient dumping. And in addition to that, EMTALA requires that we provide a medical screening to an individual without any regard to their ability to pay. So in the future, if you do walk into CMC and you need to be seen by a provider and you don't have an appointment, we will be funneling those patients to the emergency room because we cannot be perceived as blocking people from entering that emergency room. So there's a fine line, and we'll work with patients to make sure they are well aware of the same-day appointment opportunities for them. But we have to make sure that we stay compliant with the laws. If you have any of these conditions currently, as I mentioned, if you had a heart attack, respiratory distress, a significant bone fracture, abdominal issues, or a stroke, and you end up at CMC, there's very little we can actually do for you at that location. Obviously, we will try to do everything we can, but it is that ambulance ride to the next facility. But in the future, we will be able to actually stabilize all of those conditions and or treat them. And eliminate the need to travel at all if you're one of those 90%, which is, you know, we're going to treat you and street you. And for the others, we've been working with CalOR. They are planning to run fixed wing and helicopter out of the Brookings airport. So if we have to have them come get you and take you north, south, or east or west, well, not west, but they'll be prepared to do that. That wouldn't be a good situation. So really, how do we improve outcomes? And these are reports that were published by the Emergency Medicine Journal. And essentially, this slide and the next three show a significant impact in the death rate for related issues as the percent of time or distance increases. And I really wish this wouldn't keep doing this. I don't know how to make that stop. But essentially, if you have a major life-threatening event and you find yourself in an ambulance and you travel between 0 and 6 miles to get there, your death rate is about 5.8%. But just increase that to 13 miles, and in that ambulance, your chance of a death goes up to 8.8%, and that's significant. The time. I'm sorry. I don't know how to make this thing stop. I'm just gonna. I'm sorry. It's really more distracting than it is helpful. This is another relationship between mortality and a heart attack. We know that there's a golden hour to get you to a cath lab if you need that. And you can see the death rate is lower if we can get you there within 2 hours. As that time goes up, the death rate also goes up. I'm just going to pause here and see if I can fix this. Just bear with me 1 second. Mostly because this is being recorded and I'm really feeling bad about that. Let me see if I can.
Is it flashing on the laptop also, or
no?
It's the connection? Because I think it's this. I think it's the.
Is it still doing it?
Well, I just unplugged you and replugged you, so let's try.
Okay, and I went right to my eDrive. This shows the situation if you have asthma or severe respiratory distress. Again, just the time it takes to travel, the death rate goes up. And there's one more that's interesting, and that has to do with sepsis. Sepsis is a significant bacterial disease. It's fascinating as a healthcare provider because individuals can walk into a certain setting and be not feeling that sick. Maybe physicians or practitioners are thinking flu, maybe they're thinking pneumonia, maybe they're thinking things. But sepsis is a disease that rapidly progresses and will land people in the ICU all the time. It requires to be treated aggressively with antibiotics as soon as it is identified. And you can see the time just between hours. If you were to be treated for sepsis within that first hour, your chance of death is 1.03%. And as those hours increase, so does your death rate, almost by percent by hour. So we will be able to treat sepsis right there in the emergency room if we were able to spot it. Just want to share a little bit of the financial information with you. We do anticipate that we will see a net margin of approximately $835,000 per month. That's net, that's not charges, okay? So that's actually what we expect to collect. And in our business plan, we did a lot of data gathering to ensure that we were being conservative with our numbers. I'll share with you, for example, our emergency room here The percent of patients from a Brookings or Harbor zip code is about 30%. We took those revenues out of that department and we moved them into this department, and we accounted for that in our budget. We have the CalOR data to know exactly how many ambulance runs per day that they make from the Brookings Harbor Market down to Sutter. We included those. And we also looked at OSHPD data, which is a public agency that hospitals are required to report to in California. And we can actually see a lot of Sutter information by our zip code to see exactly how many patients they are treating. So we were able to determine how many patients walked into Sutter, like we drove ourselves there, walked into their emergency room and or were admitted. And we took fractions of those and applied them to this business model. The expenses will be approximately $410,000 per month. I will tell you, we were conservative in that budget in that we included traveler costs, not the cost of what a regular employee is. And the other thing that we did for this budget is we said to ourselves, when all was said and done, this looks too good. So we took our revenues down by 20% and we took our expenses up by 20% just as a cushion, just in case we were missing something. We don't think we've missed much. We do anticipate a continued need of capital expenditures over the next 24 months of about $1.75 million. The economic growth for this project is significant for our county. These were reported by the Oregon Association for Hospitals and Health Systems. And essentially what it says, in Curry County, for every 10 jobs that are added in the hospital sector, another 6.4 jobs are added in other sectors. Those are people that are working in hotels, in our stores, at our gas stations, in our movie theaters, just to support those 10 people. We anticipate approximately 33 new positions down at CMC, which will create another 21 jobs in our county. Our output multiplier for every $1 million in services or goods that we produce will generate another $390,000 in our county. We anticipate approximately $10 million in emergency room services over the year, which will add about $3.9 million worth of business to our county every year. And you can see these other multipliers, the state and the local tax multiplier. They are all significantly positive for our situation, our project. So we know the growth potential is there. We know that by expanding these services with a healthy bottom line, it will give us opportunities to continue to expand other services in the future. Remember, we are a not-for-profit public entity, and so every single dollar that's earned, it doesn't go to shareholders, it doesn't get dispersed. It stays here, it stays within the health system, and it's used to, as I said, continue to expand services. The last slide really is a dedication to all of the people in our county that have supported us over really the last 4 years. Since I got here, this has been a strategic initiative of the health system, but particularly Advanced Health. Advanced Health is one of the two community CCOs, continuity of care organizations. They are contracted by Oregon Health Authority to administer our Medicaid program. And Advanced Health heard that we really needed some help to get this emergency room open. And although we did get state funding allocated through the legislative session this last year, we were informed that those dollars would come from what are called lottery bonds, and that they wouldn't be available until 2021, and that they could only be used on bricks and mortar and equipment. And that's not what we really needed the money for. We needed it for operations. There is a chance in the short session of the budget that we can get those funds moved from the lottery funds into the general fund, which will make funds available more readily and would relax some of the regulations on what we could actually spend the money on. And we're anticipating that that will happen. But we also learned that in January of 2020, CMC will be held responsible to the brand new building codes that are just coming out. And we had an architect look at the actual building as it is today and the new building codes, and we would have some pretty significant hurdles to get over after January of 2020. So kind of with all of these kind of coming together situations, state funding not being readily available, the option for the $1.2 million short-term loan from Advanced Health, and the building codes, the board made a decision in their September board meeting to move forward to get the emergency room open. What I can tell you is that we are anticipating Oregon Health Authority to be on site in Brookings November 5th, 6th, and 7th to survey us. And after that survey, they'll give us a list of things we need to fix. Maybe we didn't have a policy, or maybe we needed to do more education or more training, or whatever they find. They'll give us a list, and we're pretty sure it'll be pretty short. As soon as we can close that list, we will be licensed and we will open the doors for the emergency room. So I cannot release a date to anybody about when we will open. We are hoping it will open shortly after that survey, but not necessarily on the day of that survey. And so with that, I'm going to open it up to any questions. Doogie.
Over 10 years ago, when this whole event started, 3 people from Brookings had died in the ambulance between Brookings and being flown out of Crescent City. Do they keep those statistics now?
Doogie, I don't know if anybody keeps those statistics. I'm sure if CalOR is in the process of transporting an individual, they would. Obviously, if we transported somebody and they died in the hospital, we keep those statistics. But I do know within the last 2 months, we had an individual come to CMC at about 4:30 in the afternoon on a Saturday, having a cardiac arrest. And although we did CPR and we called the ambulance, the patient did not survive. I'm not saying that had we had an emergency room, that outcome would have been different. Please don't misunderstand me. But I would say that we would have been more equipped to handle that situation than we were that day, which was just basic life support. It was not a full code situation with medications and a physician. So I'd like to think that that person would have had a better chance. But I don't know a count on that situation.
Well, they've got to be to an emergency room before you can be airlifted.
Yes. Yes, they do. Mm-hmm. Any other questions? Yes.
Are we still dependent in any way on volunteer EMTs for ambulance service? Last night, the NBC Nightly News said that a huge section of the country, you're in danger of calling 911 and nobody comes because police and fire are considered essential, but ambulance is not. Do we have that?
We do not have that problem. I know that we had a volunteer ambulance service, and they did a great job up in Port Orford. I understand CalOR has worked with the county and is providing services. I know they station a rig halfway between here and there. So to my knowledge, at least in Curry County, we are not subject to a volunteer ambulance service. You know, it's interesting, a lot of smaller communities, if you are on particularly the fire department rolls, and they are also EMT trained. So they've gotten away with it because fires, although when they happen you need your departments there for sure, they have a lot of idle time, and the thought was they could actually run the ambulance services. In other areas, hospitals are opening up their own ambulance services, and so ambulance services are a challenge across the country. Thankfully not here.
Thank you.
Yeah.
Do you still see a need for the traveling nurses? I mean, will there ever be an end to that, or will that be just a continuous traveling? Because I know I was in there one day and there was like 3 or 4 traveling nurses, and I'm like,
What's going on with that? Yep. So I will say we'll always have a need for short-time traveler assignments. We've got a number of staff that are out now having children, and so when you know somebody has a definitive period of time, maybe they're out on a family medical leave or something, we'll have to backfill them with travelers. Our goal, though, is to move away from using travelers for filling just vacant positions, and we're working aggressively with our Human Resources Department to better understand how we could be more competitive at recruiting and retaining our staff. Our goal is, if you ever looked at our profit and loss statement, we track our labor separately from contracted versus our own labor, and our thinking is we'd like to shift all of those or most of those dollars that we're currently spending in travelers into our own staff, whether we do that through additional education dollars or grants or base wages, but we are definitely looking to become much more competitive. I will say we've had some really good interest in bringing people here, but the ER in Brookings is going to force us to use a slew of them until we can seat our own. One of the other things that we're doing, particularly for nursing, is we've started what we call our new nurse graduate program. It's interesting when you go through your training in healthcare, you come out very academically prepared, but you have no real or very little real experience. And when you're in an isolated community, it is dangerous to bring new graduates in that don't have that experience, not because they're not well trained, but because they don't have the experience to see that is a black swan. I have not seen what that is. We as healthcare providers try to fit things into what we know versus considering the things that we don't know, which is normal and problem solving for adults everywhere. And so we've shied away from bringing new graduates into any clinical position, but this year we've gotten nurses that are willing to be preceptors. We've got 2 new nurse graduates that it's their first year out, both really excited to be here, want to live in Gold Beach and in a rural setting. And the thinking is that if we can bring in 2 or 3 new grads every year, after a couple years, we really won't have a need for nursing travelers in full-time positions. It does require, though, us to be committed to those nursing graduates, because it means they cannot work independently for 6 months or 8 months or for however long it takes for them to say to us and for us to know that they're competent, they can handle what's coming through the doors. Because I'll tell you, I remember the days, and this didn't happen here. Our chief nursing officer is wise enough to have recognized this, but in the world of healthcare too, the newbie always works the night shift. It's just and I remember at my last place, we had a treacherous event one night, and thank goodness we had a well-trained, experienced nurse in the ER. And when we looked at the scenario to understand what happened, why it happened, how could we prevent it from happening, what we learned was that all of our new nurses were being thrown on to nights. And the oldest trained nurse that we had was like 3 months into training. And so when I asked why that was, that was a union environment, it was because the more experienced nurses have tenure, and they have a right to those day shifts when they open. And so we had to fight hard to change that. Here we don't do that. We don't put our new nursing graduates alone or on nights. We partner them with another nurse. Eventually they will work nights like everybody else that Enders Healthcare does in a 24-hour situation. But we think we're setting ourselves up for success to eliminate travelers in the future. Doogie.
A doctor in the ER, can they go into the hospital if there was an emergency up there that the nurse on duty couldn't handle?
So an emergency room physician in Gold Beach, and when we open that emergency room, when you have a life-threatening situation for a patient, the highest trained individual will oversee the care of that individual. So let's say you're a patient in physical therapy down at Brookings and you go into cardiac arrest. We will absolutely call a code. That ER team will come down and they will assume responsibility. And it is typically the physician that's on that code. That's what we call running the code. And so it'll be no different there than it is here, and we will have a team of people to respond outside of the emergency department for emergency situations.
Is the hospitalist system still in our hospital?
We do still have hospitalists on site 24/7, and many of them are proficient. They can run a code, but ER doctors see so much more of it, and they're just a little bit more comfortable with it. And again, if you have 2 physicians on a situation, it is the more qualified individual, and it would be your ER physician that ultimately is responsible. And I've seen it happen many times. Hospitalists or other types of physicians, as soon as the ER doc gets there, whoop, you take it. And they are very respectful that the ER docs know how to do that better than those that don't do it all the time. Yes?
If you live anywhere north of Metos Mountain, also known as Humbug, your first decision when you move there is, do you go north for healthcare or do you go south? The old building, many people chose to go north. The new building and your team have convinced a lot of people to come south. Given that, there is no way around a detour like you had at Carpenterville Road.
Right.
If the highway goes out at Arizona, you're done. So you have to go north. So people kind of keep, even though they've switched to Curry General, they kind of keep the north in their back pocket.
It's true. You know, one of the things, once we get through this emergency room and we move more into the winter months, the board and I and the public will be invited to participate in some strategic planning. I'm very interested in Senator Hurd and Representative David Brocksmith. They are very interested in having state dollars be used in our county. And so they have reached out to say, what really do we need? And so, you know, we have some serious considerations for needs of, urgent care. I want to be very careful that we partner with Coast Community Health so that we don't duplicate services. But I do believe we will be strengthening services in Port Orford. Once we get through with this, we'll be able to kind of turn our sights up there and really understand what the needs are and what are the economies of scale. I was at their city council meeting, and I had one of the city councilors, kind of broke my heart, asked me a question, do you make more money taking care of the patients in Brookings? And the answer to that is from an economies of scale, because they have so many people, they drive the volumes. But on an individual basis, the hospital doesn't make a larger margin off of somebody that lives in Brookings than somebody that lives in Port Orford. So the answer was no. But I felt terrible that somebody would even think that that's the reason we're doing what we're doing. There are economies, though, to consider anytime.
You're healing decades of misunderstandings.
Well, thank you.
That's what's important.
Yeah.